Welcome. As we start, I would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of this land that UCSF sits on. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Land acknowledgement statements are just the beginning. It's an important acknowledgement, but it can't end there. So we encourage our colleagues and those watching to get involved with the First Nations and Native persons on whose land in which we often sit, and engage in meaningful collaboration and support. What that looks like can be incredibly varied. It can be the health field that we study, but it can also be economic, social justice things. Locally, here where I live, the university has returned some facilities to the Ohlone people, and there's a fantastic Ohlone sponsored cuisine restaurant that we are able to support. So that's just one small example of going beyond land use statements. Anyway, so thank you today. Today's webinar brought to you by the Investigator Skills Development Unit. I'm Dr. Edwin Charlebois, co-director of the Skills Development Unit within the Research Coordinating Center to reduce disparities in multiple chronic diseases. And we also support the National Health Equity Action Network that in a moment my colleague and MPI, Dr. Stuart Gansey, is going to describe what the Coordinating Center and what our Disparities network of 11 national centers does. So welcome. Apologies from our ISDU director, Dr. Mandana Khalili. She had an urgent issue she had to take care of, but sends her regrets. So thank you very much. So to hear more, I'm really looking forward to our speaker today, Dr. Debbie O. Health disparities are not distributed equally, and I think understanding both the visual landscape and the geographic distribution of disparities is a really powerful way to understand what's going on and actually to see the impact. It's a great communication center. So I'm really excited for today's talk. But first, let's hear from Dr. Gansey about the Health Equity Action Network and the UCSF Coordinating Center for NMHDs. Stuart.
Yes, well, thank you. Good morning, everyone. For today's webinar, we have invited groups that are outside of the Health Equity Action Network. And so today we'll be starting by talking a little bit about the network. Today's talk, sorry, back up one sec. Today's talk will focus on the new National Health Atlas, visualizing place-based data to identify and address health disparities. I realize now looking at this that there should be some additional names on here, folks from the UCSF Dream Lab, including Scarlett Gomez and Catherine Kemper and some others. So know that this is a project that has involved quite a few people, and this, so the Dream Lab developed a California Health Atlas several years ago, and we began discussions about expanding this to a national health atlas, and the Health Equity Action Network Research Coordinating Center has been one of the groups that has helped the Dream Lab, worked with the Dream Lab to make this happen. So next slide, please. A little information about our collaboration. Our consortium that we call ourselves the Health Equity Action Network, or HEAN. At UCSF, we have the Research Coordinating Center funded by NIMHD, which supports 11 regional research centers through a P50 mechanism that NIMHD has funded. And it's a consortium of 45 R01 level studies with 2 to 5 per center, P50 center. And then we have the Research Coordinating Center for reducing Disparities in Multiple Chronic Diseases as a central coordinating and technical assistance center. And it is the RCC that organizes this seminar series as webinars. And this is through NIMHD support of the U24 listed at the bottom. Next slide, please. And the network is, as I said, 11 P50 centers throughout the US. There are quite a few in the central time zone, as you see on the map indicated with the yellow states, but it also includes, it's a little hard to see, Illinois, Michigan, Ohio. For some reason, those are as smaller around the cities. And then here are logos of the centers, and the institutions are also listed as well. Next slide, please. And all of the centers are focused on preventing, addressing, treating, managing multiple chronic conditions through multi-level upstream interventions. Through this work in supporting this and having conversations with folks in the Dream Lab, we realized that there was a need to include some additional measures that hadn't been in the California Health Atlas. These included measures of neighborhood deprivation and segregation indices, including measures of structural factors, including structural racism. And so structural neighborhood factors can help us in understanding health disparities and health equity. In order to develop these, our team, Haley Kim and Nancy Chang, used American Community Survey 5-year data from 2 periods listed there using the RNDI package, and which calculates about 8 different measures. And we decided to report these 3 measures, which are listed here: the local exposure and isolation metric, or LEXIS, the index of concentration at the extremes, combining income and race ethnicity, and the Powell-Wiley neighborhood deprivation index. There are several neighborhood deprivation indices, and so this is the one that we have used. Okay, next slide. Okay, and so one of the things about all of these measures and all neighborhood level measures is that one needs to decide at which geographic level to calculate them. Some geographic levels are nested, such as the ones on the left. Census tracts are located within counties. Counties are located within public use micro data areas, and those are located within states. Census tracts are the smallest and states are the largest. And then non-nested areas, which are often for convenience or for other reasons to have make inferences at those levels, including zip code tabulation areas, congressional districts, and core-based statistical areas, which can cut across state lines. So these were areas that we considered, and these are geographic levels where the California Health Atlas was using many of these already, and was considering using them in the National Health Atlas. So now I'd like to turn it over to, next slide, to my colleague, Dr. Debbie O, who will talk about the UCSF Health Atlas. Dr. O is a data scientist here at UCSF. She received her earned her master's degree in London at the School of Tropical Medicine, I believe, and then got her PhD at UCLA before joining UCSF. And so please welcome Dr. O to talk about the Health Atlas.
Thanks, Dr. Yansky. And thank you to the Health Equity Action Network and for this opportunity to share our work. We've been really excited to be able to expand our tool nationally, and we're excited to see how people might be able to use it. So here's the URL. It's the UCSF Health Atlas, healthatlas.ucsf.edu. And the reason why we built this tool is because we believe that when it comes to health, place matters. And I feel like I might be preaching to the choir here, but where we live, including the physical and social environments that surround us, influences health in both positive and negative ways. So we built this tool, and it's like chock full of data and different features. I will walk you through all of them, but here's kind of a short list. There's over 120 variables that you can interact with in the map. And as Dr. Gansky mentioned, there's different geographic levels that you can choose from. We are currently sitting in a period where both the 2010 census and 2020 census geographies are being used, so both of those are included. You can choose one variable, or you can choose two variables to look at in the map. This current map has two variables, and this is, kind of Michigan, Illinois, Indiana in the, in the Midwest area. You can select a custom area. You could export the data that you want for your research. If you need some more information for background, that's also available. Okay, so just to give you kind of a sense of the short history of the Health Atlas, because you may have heard about it before, is that we started planning this tool in 2019. And we originally thought, basically we wanted to build a mapping tool for population health. We decided that we are experts in California, and we started building that out with the plan to launch in spring 2020. And as you all know, that was a very interesting time in history. And so what we thought was going to primarily be a researcher-facing tool quickly became an armchair epidemiologist. Everybody can use this tool because at the very end, the Dean of the School of Medicine suggested that we add COVID-19 data. So we partnered with the LA Times to kind of we used their GitHub and scraped in COVID-19 data. A lot of things have happened in between the spring of 2020 and now. So we've, improved our mobile version. We've added in all sorts of different data, including redlining data. Census 2020 data has been incorporated, and lots of, new features. But last year, we had a conversation with Dr. Stuart Gansky and about the need for something like the California Health Atlas for other regions in the country. And so that's kind of when we built this partnership, and finally we're able to kick off the development of national version last fall. And so that's been super exciting for us, and it's kind of been a dream from the beginning, but we just weren't sure how to make it happen. And so it's really exciting for me today to be able to let you all know that we have built this thing and we're hoping that you can use it. We had a soft launch, so this has actually been available since May, but we also developed a partnership with the University of California Center for Climate and Health Equity. And so over the summer, we kind of incorporated some more climate variables. And so now is our official launch. We have all the segregation, neighborhood deprivation, indices, and the climate data. And we are trying to tell the world, or at least the nation, that this tool exists and is freely available to use. Okay, just to give you a very, big bird's eye view of the data. We have, 5 different categories of data: demographic, socioeconomic, neighborhood, environment, and health and healthcare. These are kind of loosely based on a social determinants of health framework. The data come from a lot of different sources, primarily public facing. So if you were interested, you could get this data from somewhere else. What we do is we just make it super easy to kind of visualize, investigate, whether or not these variables are interesting for your work. And then we kind of put it all in one place. The data that you will not be able to find in other places are from the Health Equity Action Network. So these segregation indices. So these you can generate yourself, but you would have to put in a little work in order to get them. So, you know, our team has done the work and we're putting it in the map for you. We also have some climate data specific to California, which is only available in the National Health Atlas. Okay, so this is what it looks like if you have not already seen it. There is data for all 50 states, Washington, D.C., and Puerto Rico. This is, in blue is neighborhood deprivation index, in yellow is disability, and this map is at the county level. If you only want to visualize one characteristic, here's a very simple example of proportion Black or African American by census tract. And you can see that, you know, we have data for the entire country. If you wanted to overlay the index of concentration at the extremes, ICE income for race, non-Hispanic white compared to Black, you can look at those two variables at the same time. When you have a high value for both of those variables, it'll be kind of a dark green. And if you're interested in a specific region, so here we're looking at Louisiana, Mississippi, and Alabama, at the county level, you can use this selection tool. So you'll see there's like a little orange square on the right-hand side. You can use that tool to select the region that you're interested in, and you'll get population-weighted estimates for the variables that you select. So in this case, we're looking at percent non-Hispanic white and percent Black or African American in these counties in these states. If you want to export data, you can do that. We have, you know, some options. If you want to select all the data, that is fine. If you only want, you know, in this case, just these data for these 3 states, you can do that. I selected census tract. So if you have census tract level data that you want to attach to, the Health Atlas data, you can do that. And then there's a data dictionary in case you just want more information. If you want maps, you can also download a map and customize it a bit. You kind of like close these windows if you're not interested in them. I personally just like taking a screenshot, but realize that, you know, sometimes different screens have different resolutions. So sometimes this is just a really easy option to get a good quality map. A new feature that we have is tags. And so you can, you know, in this little, using this little magnifying glass, you can just type in the characteristic that you want. But if what you want is something like ozone, you might not know that you're looking for ozone. So we have a few categories. So like cancer, children, climate, heart disease, older adults. And that just makes it easier to find some of these variables. Okay, so I gave you the big view, big bird's eye view of the data, and now I'm going to take you to the very super granular view of the variables that are in the map. We have demographic data on age, sex, race, and ethnicity. I do want to highlight the fact that we have very granular race and ethnicity data. Our team decided that as we were expanding nationally, that we wanted to be able to include groups that are relevant to the entire country. And so we put a cutoff of if there's a group that has over 3% representation in the United States, then we would include them. So you can see it's a pretty long list. For our socioeconomic data, there's various socioeconomic indices, including the neighborhood deprivation index. We have different measures of poverty and income, different measures of income inequality, employment, education, digital access, and neighborhood data. So neighborhood data is an umbrella for a lot of different things, including, you know, the denominator for many of these variables, so the total population, but also household data, language and ethnic enclave data, housing data, because we know that housing is very closely tied to health often. Also in neighborhood data, we have built environment, so things like parks and food access. And in purple, you see here the new segregation variables, which Dr. Kansky will talk a little bit about after I introduce you to this, to all the things. We also have historical redlining under structural racism, measures of rurality, and different measures for transit. In terms of environmental data, we have air pollution measures, heat measures, extreme precipitation, and different environmental indices. Some of these, such as the heat measures and extreme precipitation, are currently only available for California, but hopefully in the next year or so, we'll include data for the entire country. And lastly, there's health and healthcare data. A lot of this is taken from CDC places. So these are kind of estimates that the CDC puts out. And it ranges from things like depression, asthma, obesity. We have different measures of healthcare access, healthcare use, and health behaviors. And here is a short list of all the people that put work into making this happen. I want to thank, well, I see Catherine Kemper here, and I don't think that Mindy is on the call today, but really this has been a team effort and a labor of love over many, many years, and it would not have happened without the support of all these folks. Okay, so again, here's a URL if you want to check it out yourself. I would say if you are interested in looking at it on mobile, that, the maps are fine, but there are more features in the laptop desktop version. So just a word of caution. And then if you do want to use it, there is a citation. You can also find the citation in our FAQ, but just so you know that there is a suggested citation. Okay, so next I'm going to hand it back over to Dr. Gansky.
Debbie, what platforms do the desktop run on? Just Windows or Windows and?
Yeah, it should be fine on Windows, Mac. It should be fine on any type of browser.
Okay. Oh, okay. It's browser run. Okay.
Yeah.
Okay, maybe this is a good time to pause and see if there are any additional questions.
Oh, sure. I'm having a hard time opening the chat, but
yeah, so in the chat, there's a question about whether there's any need for special permission to propose using the Atlas as a data source in grant applications.
there's no need. So this is what we are hoping that you do. We are hoping that you use it for your grant applications. It's all freely available. I would say that citing us would be great, just because that would help us get the word out so that people can use this tool. Any other questions?
And then there's
Yes,
another question about mental health data. And so you may want to back up a slide or two just to show those. Yes, there is.
For mental health, that is perhaps the only one.
And I believe depression.
Depression. Oh yeah, depression.
And I think the health outcomes come from BRFSS.
Well, so it's a little bit more complicated than that, and maybe Catherine, you could correct me if I'm wrong, but I believe that BRFSS data is only for specific regions in the country, and so what CDC did is they used that data and modeled it so that all census tracts all over the country can have estimates. So these are not hard data; these are estimates that CDC puts out through CDC places. So I see Dr. Brown has his hand up. Want to shout it out?
Yes, absolutely. So what are some of the features of the California Health Atlas that are different or still not yet in the National Health Atlas? One thing that stands out to me is there was this really cool feature called like stories in the California version that kind of told a story about the progress and kind of happenings of neighborhoods from a data perspective.
Right. Yeah. So when we moved to National Health Atlas, we felt like the California stories weren't necessarily what we wanted to feature. We wanted to be able to kind of make a level playing field. So we have not yet incorporated those, though we are open to suggestion. We've found that those stories were super interesting to create, but it was not very well utilized. So we weren't sure
I had
if there's a demand. Certainly, we are happy to create more, but we found that there was not a lot of usage of those stories. Some other features. Oh, go ahead.
Would there be an opportunity for, so you said you all created the stories. Are there instances where the people who contribute the data, such as people from our consortium, could create stories?
Yeah, if somebody has an idea and wants to reach out, certainly we would be open to talking about it. I mean, I think that would be really interesting, and maybe we can get creative about presenting in a different way where people can utilize it more or would utilize it more. So yeah, feel free to reach out. Catherine, maybe you can drop in the Pop Health email address. That might be an easy way for people to contact us.
Thank you. Really great.
Great.
And then we've got some questions in the chat.
Yeah, I haven't addressed some of them, and I don't know if we want to finish the presentation and then come back to those items.
I leave that up to you.
Yeah, maybe we'll do that and then come back to more of the questions.
Which might be answered in what you're presenting.
Yeah, some of the questions will be answered by this information. Exactly. Okay, so as I said in the beginning, one of the features that we were really interested in adding involved structural racism and additional measures of segregation and additional measures of deprivation. And there is a function in R called NDI, which can be used to calculate about 8 different measures, and some of them are more neighborhood deprivation, which are more socioeconomic, and some of them are more related to segregation, and some of them are related more to structural racism. Because you saw the lengthy list of variables that are already included in the Health Atlas, as is the case with anytime we are analyzing data or one collects or analyzes data or reports data, subjective choices have to be made. And so we evaluated the options for which indices to include and decided based on the properties of these measures, the literature on these measures, and the fact that these are different than measures that are already included in the Health Atlas. And so that's how we came up with these particular measures. So the first one I'll talk about in a little more depth is the local exposure and isolation metric. This was proposed by Bamanian and Beyer in 2017. And this estimates of 2 people interacting, 2 people from racial ethnic groups. And so it's available for these groups, non-Hispanic white versus non-Hispanic Black, non-Hispanic white versus non-Hispanic Asian, and non-Hispanic white versus Hispanic. A lot of these measures, when sample size gets small or when geographic regions get small, some of these measures kind of break down. They get unstable. And so that's why we chose those groups, because of the the percent of people in the population across the country and at the geographic levels that we were looking at. And then you choose one small geographic region and one large geographic region. So we picked census tract versus county, congressional district versus state, county versus state, and PUMA versus state. So basically it's comparing the probability, the logit of the expected probability of two people interacting at the bigger area like county compared to the smaller area like census tract. And so the metric itself is a standardized logit of the estimated probability of two people in a subgroup, two subgroups, two people, one from each subgroup, interacting in the small area, and then centering that on the logit of the expected probability of the large area of the same interaction of the same subgroups, so that it's standardized. Next slide, please. So another way, so there's also the interpretation. So if Lexus is equal to 0, then there's no difference between the small area and the large area of the logit of the probability of two people interacting. If it's greater than 0, then the small area is less segregated than the large area. And if it's less than 0, then the small area is more segregated than the large area. And as the graphic shows, it's looking at the small area like census tract comparing to the large area like county. And it's the probability of the two people interacting. Next slide. So it has been published in 2017. There have been some applications where people have reported using this. And so one is this paper by Khalili in 2023. They looked at isolation and survival. And so they looked at the impact of local and metropolitan statistical area isolation on survival in non-Hispanic Black women diagnosed with breast cancer in the US. And they used a SEER Medicare cohort of people. They wanted to look at the relationship between Black isolation and survival among older non-Hispanic Black women with breast cancer. And what they found can be summarized in these two graphs. So they looked at all-cause mortality, and they found that non-Hispanic Black local isolation increased all-cause mortality, but that non-Hispanic Black metropolitan statistical area isolation, which is larger, increased mortality more. And they also found an interaction between these two, which is, instead of synergistic, it's antagonistic, which means that adding these two effects of local isolation and metropolitan statistical area isolation together reduces the individual amount of isolation effect. And then they found had similar findings when they looked specifically at breast cancer mortality, and to a somewhat lesser extent, and with some of them not being statistically significant. So this is an example of how people have used Lexus in the past. They found this rather complicated relationship, and so it's worth looking at this kind of interaction effect further, and perhaps in other health areas, in other outcome measures, and then trying to understand why. Next slide, please. Okay, so the next index is the index of concentration at the extremes, which this particular one is combining income and race ethnicity. And this was published by Krieger and colleagues in 2016. And it's been used fairly widely as a measure of segregation and structural racism. And the way this measure is constructed is to look at two racial ethnic groups and income subgroups. And so looking at a non-Hispanic white privileged group, and I'm using the terms that Krieger and colleagues use, privileged group of being in the 80th income percentile, and comparing them to other groups, other racial ethnic groups that are deprived again, using the terminology of Krieger and colleagues, which is 20th income percentile. And so we have calculated that for Blacks, including Hispanic Blacks, Hispanics, and Asians, including Hispanic Asians. And so it's comparing these extremes, which is why the index is named as it is. The interpretation is that if it's 0, the area is not dominated by extreme concentrations of either group. If it is 1, it is the most extreme in that all residents are in the most privileged group. And if it's -1, then it's extreme in the other direction in that all residents are in the most deprived group. Next slide, please. And so this has been used in studies. This is one from 2024 by Saley and colleagues. And it's looking at racial and economic segregation and diabetes mortality in the US, 2016-2020. They're looking at the association between racial and economic segregation and diabetes mortality. I think we cut off a little bit there from 2016 to 2020. And they compared 3 different kinds of ICE, or index of concentration extreme at the extremes: income alone, race alone, and the combination. The Health Atlas only includes the combinations because we already have different measures of income and race. And then he categorized these into quintiles, where the highest concentration was the first quintile, and the lowest concentration is the 5th quintile, comparing low income non-Hispanic Black and low income non-Hispanic Black households. And so they show a very strong income effect. Almost the risk ratio is almost 2. And they show a significant race and ethnicity effect of about 1.3. And then for the combination, they show about 1.7 as the risk ratio. One of the advantages of using this combined ICE variable instead of, say, the income separately and the race and ethnicity separately, and including both of them in a model, is that the combined effect actually has less problems of collinearity if you're putting a lot of variables into a model. So they found that counties with the lowest concentration versus counties with the highest concentration had increased diabetes mortality. Okay, next slide, please. And here's another application. Again, this is a 2024 paper. When we think of ecologic analyses of geographic area data, we often see them as cross-sectional, and this is showing over time. And so one of the things in HEAM that we're trying to do is not just admire the problem or describe health disparities in more and more detail, but actually create health equity and come up with solutions. And one way to monitor how we're doing, are we progressing, are we making a difference, is to look at these measures over time. And that's what this Das et al. Paper looks at. So they look at dynamic changes in place-based measures of structural racism and preterm birth in the US. They wondered whether there was a decline in structural racism over time, and whether that decline related to reduced risk of preterm birth. And they found that over this time period, that from 2014, 2006 to 2010, and 2014 to 2018, that there was reduced county level concentrated non-Hispanic Black poverty, and there was lower preterm risk as measured by the incidence rate ratio, particularly among non-Hispanic Black populations. And so they estimated, they use a standard deviation as increase in ICE, and looked at how that related to the IRR, finding that there were positive changes over time. Next slide, please. Okay, the last measure I'd like to talk about is the Powell-Wiley Neighborhood Deprivation Index. This was published in 2019, and this index, Powell-Wiley and colleagues conducted a factor analysis to find. I don't know why my phone thinks I'm talking to it. I didn't say GOOGLE or any other word like that, but these things happen, technology. So they conducted factor analysis on 13 sociodemographic measures of household income, wealth, housing conditions, education, employment, occupation, shown here. And they created this index based on that, where higher values indicate more deprivation and lower values indicate less deprivation, which corresponds to the opposite of less deprivation is greater resources and opportunities. More deprivation is fewer resources and opportunities. Next slide. And in this paper, this is their paper in 2019, then after developing the measure, they looked at the relationship between neighborhood socioeconomic deprivation and telomere length, which is a measure of premature aging. And so they looked at the leukocyte telomere length, or LTL, and NDI in tertiles, low, medium, and high. And they have 6 models. Models 3 through 6 include the variables, the adjustment variables in models 1 and 2. And they're listed below in the note, but basically it's showing that there's significant relationship between NDI and shortened telomere length or premature aging. So this is an example where you can adjust for a lot of variables in the neighborhood that are condensed into one measure. Next slide, please. Okay, so that's what we have today to share with you about these new measures added to the Health Atlas, and about the Health Atlas going national, including all 50 states, DC, and Puerto Rico. And so thanks for your attention. I see that there are some additional questions in the chat, and we're happy to address those as well as others.
Great. There's a question from Katrina Abubara. Are there examples of researchers who have linked these data to other national data sources like the All of Us data or claims data that you know of?
So the, excuse me. So the National Health Atlas is relatively new, but certainly for the California Health Atlas data, we've used it. We've published a number of COVID papers. And I just want to kind of reiterate that all of these are public sources. So there's many people who have used, resources like CDC Places or census data and attached it to their data sets and published on it. If I had more time, I would look up, different papers to kind of drop in the chat, but maybe Catherine has some, that's something else, sorry. It's hard to keep up with the chat and talk at the same time.
Ichen had a question. It seems like you used a lot of different data sources to generate these measures, for which For those data, that did not come from the census, is there any possibility that selection bias, led to some biased estimates of actual characteristics of the neighborhood? And Khalili, you had a response.
Yeah, I think that yeah, it's a really important question that we are not free from. We have to think about those issues at every time. So as far as I know, like House Atlas team clarified the data sources for every measure, but if there's any unclear understanding about the data source or the year that the data obtained, please reach out to the Health Atlas team for the clarification. So the Health Atlas team can modify the data. Adding some details. Thanks.
And Kristen Alexander had a really great question. Like, is there mental health data, diagnoses, ICD-9 codes, or anything that's unmet? Are there measures of unmet, mental health needs anywhere in the data set currently?
Yeah, so I think we did address that one, that there's depression and
Poor
an
mental
overall
health.
mental health,
Yeah.
low mental health.
And those are taken from CDC places.
So
Right.
just
And
diagnosis
CDC
rates, but not,
places
yeah. Okay.
is the small area estimates from BRFSS, the Behavioral Risk Factors
Survey.
Surveillance Screening Survey.
Other questions? Go ahead and raise your hand, and you can ask them directly so that
And then there was a question about the definition of ethnic enclave, which Catherine answered in the chat. Catherine, I don't know if you want to say more.
Sure. Those are measures that were generated by the Dream Lab at UCSF. And right now they're just for the state of California for Hispanic ethnic enclaves and Asian Pacific Islander ethnic enclaves. I linked the methods paper that generated those measures in the chat. And we also have a description of them on the website, but they combine several variables from the American Community Survey to create those indices.
So it's like multi-dimensional clustering of language and ethnicity density and those sorts of things.
Yeah, I believe they used a PCA analysis to combine the measures of language and race and ethnicity and other factors. Thank you.
I should note that the Dream Lab is working in combination with a number of collaborators across the US to generate ethnic enclave measures, updated ethnic enclave measures for places outside of California. So just to have some sort of a uniform variable to use. But I know that ethnic enclaves are very different in different parts of the country. But maybe in the next round of updates, we might have that variable.
I see an additional question came in through the chat.
Oh, Shuang Liang asked about will FQHC or health center data related to will be available in the future using street address or anything of the centers, catchment areas of FQHCs or anything?
I mean, I think that's an interesting suggestion. In the California version, we did have a feature where it just made it really easy to select, say, the 9 counties of the Bay Area, or the 25 counties in the UCSF Cancer Center. But in terms of searching, just like to get to that area, you can use the address. There's like a little magnifying glass, I believe it's on the right side, to just type in the region that you're looking for.
And then a question about the future. You had a wish list or of kind of things you'd like to be adding in some of the previous updates. What do you, in terms of the uniqueness of what the Health Atlas could offer, disparities researchers, what's one thing that you might prioritize if you had unlimited resources? Like what would you what would what would you add that would even make this a more terrific resource for analysis?
That is a great question. And I mean, this is a question where I would love for people to tell us, what they would like. I think our next steps would be not to change the tool. I mean, of course, we want to work out the bugs and, add variables as needed, but to really get it into the hands of people who can use it. Because if we just have a website and, it's just pretty maps, then it's not, we haven't achieved our goal. Our goal is for people to be able to look at the map, find the data they want, and, work in their communities, to publish papers, to affect policy. So that is really what I would like to see. I can't put a dollar amount on that, but I think that takes, it's kind of more work than it is money, right? It's more advocacy and, talking to the right people than it is about dollars.
Are there any training videos on that walk people through it?
Well, if you go into the website, I believe up in the upper right-hand corner, there's like a little question mark. It's not a video, but it's just like a walkthrough. And it can show you step by step, how to use different features. We are in the process of making little training videos. The problem with training videos is that they get out of date fairly quickly. So it's easier to put something like a walkthrough where as we update, we can update those walkthroughs. But certainly this, this recorded talk would be a great resource for people who might want to use not only the Health Atlas, but like some of these measures of segregation and neighborhood deprivation. And yeah, I think we can think about maybe short videos that we can post just to teach people how to do, simple things like selecting one variable, selecting two variables, downloading the data. I think that's a good idea.
That and then, how to present in the paper, walking people through that whole step. I think it would be great. Well, we're gonna make this available, the video of this session available. And Debbie and colleagues have also generously agreed to let us have a copy of the slide deck, so we'll make the slide decks available to on request. And of course, you'll have the contact information for the Dream Lab, the Health Atlas team, and Dr. O and colleagues themselves.
Thanks so much.